So I'm going to, Mitsuko and myself are going to ask each other's questions.
Yeah.
And I'm going to learn from Mitsuko.
Okay.
And we're going to start off by a patient who is on gestational age. Mitsuko and Simon are 33 weeks pregnant.
Yeah.
So we're going to start off with a presentation down to the urinary bladder. Then the baby is in cephalic presentation. The spine is to the maternal left, and fetal heart motion is present. And we sweep up to the fundus, and we then don't say anything. Translator, please do not translate this because I don't know if the mother wants to know gender. And we come up to the anus, the sphincter, anal sphincter, the target sign, and then onto the genitalia. The genitalia are always important when it comes to ventriculomegaly. So that's the single sweep, and then I go from left to right. And I can conclude there is a single live baby in cephalic presentation at 33 weeks of gestation. My next step is what probe do I use? And when I select, I have the options of an intercavity probe, a C1 to 9 probe, and there's also a 5 to 9, which is a very nice probe, and then there is a RM7C. We're using the RM7C today. So we select the probe RM7C, and the next thing to do is to maximize the image. Now to do that, the first thing is my sector width. On this default setting, I need to widen the sector width so I see the full width of the fetal head. The next I need to do is to reduce my depth. So I do 1, 2, 3 clicks on depth. And the next, my acoustic output is at 100%. And the next I do is to increase my gain. From that point, I then, once I've done my depth, I then do very slight magnification, not by total zoom, but by HD zoom.
Oh, beautiful.
And then my settings are radiant mid, and radiant max. And then that gives me nice definition.
Okay, take another seat.
So if we, with Zuka point out, if we look down lower here, we can see the definition of the fetal skull. And just we start with a very basic examination, which is the Isiwag section analysis. So for the Isiwag section analysis, we're going to do a whole quadrant. I'm going to magnify the image up, and I'm going to start off looking at the midline falx. I'm going to magnify that image, and I can only see one line of the midline falx, and it extends all the way from anterior to posterior. I can see here the cingulate gyrus coming in at this point here. I then come down to the next section, I update my image, and I come down to the next section looking at the ventricles. I have an anterior landmark and a posterior landmark. If I can just bring up the pointers and they help me, the arrow. I bring up my landmark of the cadence septum pellucidum, and I bring up the landmark of the cerebral lateral ventricles, Isiwag section number 2. And then the next after that is to update my image and come down to the cerebral peduncles, this tiny little slit in here, the aqueduct of Sylvius, which is very hard to see in this late stage. These are the cerebral peduncles, these are the thalami, and then I need to get my cadence septum pellucidum in view. So I have to have my CSP and my cerebral peduncles. This is the point at which we take the BPD measurement. The third measurement, to bring it to view, you will see I rotate my probe, so I come in through the posterior fontanelle to demonstrate the cerebellum. This is the right cerebellar hemisphere. This here is the vermis. This is the left cerebral hemisphere. This is the roof of the fourth ventricle, which is triangular in shape. And I have my cadence septum pellucidum anteriorly. These are the 4 sections which we are looking at, starting off from superior to inferior in a basic axial assessment of the baby's brain. In the axial section of the baby's brain, there are more things we can see. Mitsuko, what would you like me to show?
I'd like to see the optic chiasma.
Let's go straight into the deep end, the optic chiasma. So for the optic chiasma, I go down to the base of the brain. So this is up at the superior, down to the level of the midbrain brainstem. I go down to the base of the skull, the transcerebellum, and then I go right to the very base of the skull. And I look at this point here, which is the petrous part of the temporal bone, which is like a tram track, and I see the pulsation of the middle cerebral artery. And then I zoom, and I see the middle cerebral artery coming out here, and I have in here pulsating is the circle of Willis, and this is called the pentagon.
Pentagon.
Yeah, where all the intelligence takes place in the baby. And then here we have our optic chiasma. And to show this, I will put on Doppler, and I will use color Doppler evaluation. And as I look with color Doppler, I have a number of choices. I can start with straightforward color, and if I use straightforward color, I reduce my PRF to 12 centimeters a second, because I want to see the communicating arteries and the full circle of Willis. My next step is then go from color, is then to go to power Doppler. Power Doppler is more sensitive flow. I increase my acoustic output, I drop my PRF to 10 centimeters a second, and then I slightly increase my power to bring in the circle of Willis into view. That's the third, that's the second, and then the third is slow flow. And slow flow has got a background on it, so I can choose to split my image into 2D and color. I can reduce my box size, and when I'm in this box size, then I can turn the background off. So I'm demonstrating the circle of Willis, the middle cerebral artery, the anterior communicating artery, which I mentioned is absent in babies with holoprosencephaly, which is present in this baby. But Rasuko did ask me, Simon, show me the optic chiasma. And the optic chiasma is to go down to the circle of Willis. And when you see the pulsation, you know you're in the region of the circle of Willis. But when you see the optic chiasma, you're only seeing the posterior component. You're not actually seeing the optic nerve. And to bring that into view, you need to come down to bring the optic chiasma into view, and at the same time, try and catch the orbit of the baby's eye, because you want to see whether the optic nerve is present. This becomes important in septo-optic dysplasia, and as you come up to magnify the image of the baby's eye, you can then try and turn around and catch the point where the optic nerves leaves at the back of the baby's eyeball. And that can be challenging, but let me try. When you are looking for the optic chiasma and you're trying to see the anterior optic tract, you're trying to bring in the chiasma and the orbit in the same view. So you catch the orbit and then you catch the optic tract. And this is the point where you'll be able to see from the optic chiasma, you will track the anterior part of the optic chiasma heading up to the optic nerve.
But most of the audience, maybe they think that optic chiasma is like the Chanel sign, with it, the X, and the X. However, that's the only the things the posterior part of the optic chiasma is seen by the.
And that's the point that Mitsuko is making, which is very relevant. We're just seeing the posterior portion of the optic chiasma. To see the anterior portion, it is very challenging, in which you try and bring the orbit, the optic nerve into view, and sometimes you may rely on the vaginal scan.
So, but Simon, why you are looking at the optic chiasma?
In this baby, I would not look at the optic chiasma, only because you asked me.
But is this your routine?
No.
No.
So my routine would be to start off and measure the BPD, the head circumference, the sectional planes from superior to inferior, and then the next step of the baby at 33 weeks, I would check the posterior cranial fossa,
Yeah.
just looking at the cisterna magna, looking at the vermis, which I will do in 3D section. I check to see that the Sylvian fissure, that there's operculization at 33 weeks. So we can see posteriorly there's operculization and anteriorly there's operculization. So it comes up to this point and goes out and out. And this is exactly what I expect for 33 weeks.
So how about the olfactory sulcus?
Oh, the olfactory sulcus, well, I'm going to hand over the probe for you to show that.
Yeah.
But before I do that, I'm going to just come in and take the 3D of the cerebellum. So as I do that, I catch the point where the cerebellum comes in, and anytime you're doing a 3D reconstruction, you catch the vermis, you catch the roof, and try if you can see the cingulate gyrus or see the cavum septum. And once you have it in view, you then select your quality to max, and then you select your volume angle up to 80, and you ask the patient to hold her breath. So stop breathing for a second. So 5, 4, 3, 2, 1.
Your second is very long.
Yeah, my seconds are long. Yeah. Maybe I should count 10, 9, 8, 7,
Okay.
6.
Okay, good.
So now we are left with a multiplanar and render, and I have no interest in the render, so I click the multiplanar.
Multiplanar.
Yeah.
Yeah.
And then once I've got the multiplanar up in view, I then translate through the volume to see did I catch the fourth ventricle. And this is my reference point here,
Yeah.
which is my triangle in the fourth ventricle.
Fourth ventricle. Okay.
If that's okay, then I will rotate around the z-axis.
Yeah.
Bring it up towards 12 o'clock and place my reference dot inside the fourth ventricle. But my cerebellum is not symmetrical, so I will need to then translate through the volume until I make sure that my cerebellar hemispheres are symmetrical. And then once I have them lined up, I have my volume speckle reduction imaging. I put that up. Mitsuko already has this on her default, but I put it to volume
You
speckle.
can change anything.
But it's
But I usually know that we use
Three
three
planes.
orthogonal view to
Work it
adjust.
okay. So
But-
I'm going to get you to do that in a second. I'm going to let you take over the probe. And we actually my way, then you should be your way. So we then go to the A plane, and I generally manipulate the A plane. So after getting it in the A plane, I then rotate on the Y axis. And the reason that I do that is because I like to get work on my orthogonal planes and translations through my volume to see the fourth ventricle. There's my fourth ventricle. You can, if you want, place a reference dot in the fourth ventricle if you've got, say, Blake's pouch and you want to see if it's anti-clockwise rotation. I prefer put it in the vermis, and then I rotate 90 degrees to see whether I've got a view of the vermis. Once I do that, then I rotate around the Z-axis, and then I hit my VCI. And then once I'm in VCI, I then select sepia, and I go to sepia of ice, and then I magnify my image, and I can take my anterior posterior height, and then my this up to my vestigial point, and then I can do generic calculate area, and then can trace the area. And I would not do this routinely. It would only be in the setting if I was suspicious if there being a vermian hypoplasia, and I'll measure the area of the vermis. Now, doing this in terms of a vermian morphology, this is on a 3D reconstruction, but if we were to go to a vaginal examination, this would be much clearer looking at this on real-time 3D. If I wanted to clear my measurements and go to tomographic ultrasound slices, I can then look from my right to my left cerebellum. So this is the cerebellar hemisphere on the right, the cerebellar hemisphere on the left. I can choose then to open my thickness or distances which I have going across. So that includes from right to left cerebellar hemisphere. Or if I just want to look at slices of the vermis down to the thickness of 1 millimeter, then I can choose that. I'll do a slight rotation of the Z-axis. And if you want some fine tuning of the X-axis, brings in more clearly the superior border of the vermis. So that's a 3D reconstruction. And before I hand over the probe, because you're going to show me the temporal lobe, you're going to show us how to do using multiplanar analysis. Or maybe you do that now too, but
No, it's okay. So
You want to keep going?
yeah, and I think the posterior frontal visualization is somewhat in 33 weeks of gestation or late pregnancy. It is much better to use transabdominal sonography
Yeah.
because the transvaginal sonography from the anterior or even posterior fossa, as a window, the ultrasound window, is much far from the transducer to the posterior fossa. So maybe this is a very good because there's a lambdoid suture
Yeah.
in the posterior, and also you can use anterolateral fontanelle just behind the ear. So maybe it is very very clear to see
Yeah.
the posterior fossa and the myopia.
And using that radiant max gives a very nice definition of the foliation of the cerebellar hemispheres. Gives nice definition. Also gives nice definition of the operculization that you see of the Sylvian fissure. And also the parietal occipital fissure is another fissure that's important to see at this stage. And Suko,
Yeah.
when you were doing a lateral ventricular measurement, do you do it according to the ISIO guidelines, where you show the cavum septum pellucidum and you show the glomus of the choroid and then measure at this point? Or do you take the measurement of the lateral ventricles where you see the parietal occipital fissure, which is here, and it drops down to here? Do you measure the lateral ventricle at the tip of the parietal occipital fissure?
I usually use a ISMO guideline, the anterior complex, and looking at the choroid plexus
Yeah.
of the lateral ventricle and the base of it.
Yeah. Okay. And I
Okay,
think
question.
that's an important message. Ritsuko, can you tell me, with regard to the anterior complex, are you happy with what I'm demonstrating, the anterior complex, or would you like to see something a little bit more clearly? Do you do 3D when you evaluate the anterior complex?
I always use the transvaginal sonography
Yeah.
for looking at the exactly symmetrical structure of the anterior complex.
Yeah.
So therefore, it's good. But Simon, before, for example, before 18 weeks of gestation, we cannot see sometimes that we cannot see this septum pellucidum.
That's a good point, and I think in terms of today, it's an important message which we need to convey is that sometimes you will find that you cannot see the CSP. If you read in the textbooks, it says the CSP appears around 15, 16 weeks of gestation in many pregnancies, but in some, 17, 18 weeks, would you agree that you cannot see the CSP? It appears a little bit later?
I think the maybe most of the cases at 15, 16, 17 weeks of gestation, we cannot see even by the transvaginal sonography that there's no CSP there, and even the first half of the 18 weeks of gestation, sometimes that we cannot see the CSP.
Yeah.
So maybe if CSP is a kind of the landmark, maybe the many of the audience